Hello, and welcome to this episode of In Discussion With from Medical Update Online. Today I'm talking to Kieron Power about a pharmacist-led outpatient pulmonary embolism pathway that has delivered excellent results. So, Kieron, please can you start by introducing yourself?
My name is Kieron Power, and I'm the Principal Pharmacist for Thrombosis and Anticoagulation in Swansea Bay University Health Board in South Wales.
And can you give us a brief overview of what your current job involves?
So there's three aspects to my role. The first is I'm the Health Board's Thrombosis and Anticoagulation lead, which is a governance role. So I lead on all of the policy and guidance within the Health Board. Things such as how we perform as a health board in terms of things like hospital-acquired thrombosis rates and VT risk assessments and general anticoagulation prescribing factors. The second is that I do a once-weekly thrombosis and anticoagulation specialist clinic on behalf of our consultant haematologists. And the third, which is the part which I'm here to speak to you today around, and I'll go into this in a bit more depth as we proceed, is that I also lead and run the pharmacist-led acute VT service and follow-up service that we operate within our health board.
You recently presented a poster describing a pharmacist-led outpatient pulmonary embolism pathway, and this is what I want to talk about today. But first, could you just remind us, what is a pulmonary embolism?
So pulmonary embolism comes under the umbrella term of conditions venous thromboembolism, or VT, which most people would have heard of. And fundamentally, they are made up with the two most common presentations, which is DVT, which classically occurs in the legs, but can also happen in the arms, and P, or pulmonary embolism, which occurs within the lungs. And fundamentally, what pulmonary embolism is where a thrombus causes an occlusion to the pulmonary blood circulation, which then can lead to pressure developing within that circulation. Now, DVT and P are actually pathologically similar, which is why fundamentally we treat them in the same way long term. But PE is actually the most serious consequence of VT and has a mortality aspect to it. So that's the condition which people would likely fear more from that perspective. So it's prevalent within the UK. We see the estimates vary, but it's around about 39 to 115 per 100,000 of the population each year will develop a PE. And especially in the past, where there haven't been effective treatment methods, there can be a very high mortality rate. So we know that in patients who aren't treated effectively, there can be a mortality rate of up to 30% in PEs. But actually, what we've started to realize in recent times is that not all PEs are the same. And actually, there's distinct groups within that bracket of PE as well. And what I mean by that is some patients present with very high risk PEs. And not to go into a biology lesson, but what we believe happens is when patients have large thrombi, especially in those central blood vessels, which are coming straight within the pulmonary artery, what can happen then is it causes a lot of pressure on the right side of the heart, which then can lead to patients going into hemodynamic compromise and presented with hemodynamic instability and actually being extremely unwell patients. Now, these are critically unwell patients, and these require hospital admission and considered for high-risk procedures such as thrombolysis. But the other end of the spectrum, you get patients with much smaller emboli, which develop within some of the peripheral blood vessels, who may not need that urgent level of care and may actually present with slightly more vague symptoms, often things like pleuritic chest pain, and may well have presented first to their GP, for example, been treated for things like chest infections, not seen improvement, and then thought, gosh, we need to rule out a PE, and that's where they eventually get diagnosed. So actually what we've seen is that we shouldn't consider PE to be one entity. There are different risk groups within that condition.
And now, could you walk us through current treatment for pulmonary embolism?
So essentially, one could argue that to an extent, P's in terms of presentation, alluding slightly to what I mentioned earlier, are slightly self-selective in terms of where they present. So as I mentioned, patients with very large emboli, where there's a lot of strain on the right ventricle, they will often present with things such as syncope or collapse or quite significant symptoms of shortness of breath, often will ring 999 or present to an A&E. And those are the patients that I mentioned who are admitted, and those are the patients who are considered for thrombolysis. So we know that thrombolysis has good evidence in terms of reducing mortality, but with an associated bleeding risk. So those patients are mainly reviewed by senior clinicians who specialise within acute medicine, and they're kept in hospital where they'll receive usually parenteral anticoagulation before being discharged on an oral anticoagulant once they recover and they stabilise. The lower risk group, as I mentioned, often will present to their GP practices because they develop, like I said, these slightly less significant symptoms, don't feel often that they're that unwell to present to A&E, and will be referred down often to ambulatory pathways, to things such as same-day emergency care units, which is where I work. And usually in those units, patients will be assessed, sent for a CTPA usually on the day, and then managed as outpatients instead.